Great. Good morning, everyone. We're going to go ahead and get started. My name is Kaylin Ostrowski, and I have the good fortune of serving as Director of Advancement for the Global Health Institute and Strategic Advisor to our Planetary Health Scholars Program. For those of you who are new to the Global Health Institute, we are a unit at the University of Wisconsin-Madison dedicated to improving and inspiring collaboration across campus and around the world, educating tomorrow's leaders, and promoting research and outreach to improve well-being for all. On behalf of the University of Wisconsin-Madison's Global Health Institute, I would like to welcome you to the third event of a four-part webinar series entitled COVID and Equity, What We've Learned, Where We Go From Here. GHI works at the intersection of health, equity, and sustainability. Our work is grounded in a global health ethic that recognizes the health of humans, animals, and the planet's ecosystems are inextricably linked. We work locally and globally, and our team has been involved in the COVID response from frontline care to policy advocacy. We developed the COVID and Equity webinar series in response to the significant health disparities illuminated by the pandemic in Wisconsin and across the world. The challenges of equity and systemic racism have been further magnified as protests over the death of George Floyd and others from police brutality ignited a movement for justice locally and globally. GHI has brought together a diverse group of campus, community, and international voices to examine the lessons we've learned from the pandemic and to translate these lessons learned into actionable next steps for policymakers, program managers, researchers moving forward. Today, we welcome four incredible voices from across the world who've been at the forefront of the Ebola and COVID-19 pandemics in Liberia. They will discuss how they are translating lessons learned during Ebola and how they are integrating these experiences into their COVID-19 response. A few housekeeping items. I'd like to remind everyone that this session is being recorded, and a link to the archive video along with an event summary will be available on our website. If you have any questions for the panelists, please type them into the chat box by clicking on the chat bubble at the bottom. I'd also like to thank everyone who helped organize the event, including our moderator and our panelists. Now, without further ado, I'd like to introduce our moderator, my colleague, Dr. Janis Tupesis, an Associate Director at UW-Madison's Global Health Institute and faculty member in the Department of Emergency Medicine at the School of Medicine and Public Health. Dr. Tupesis has established an international reputation for his work with graduate medical education and emergency medicine in resource-limited settings, especially Liberia, Ethiopia, and South Africa. He works with the World Bank's Africa Centers of Excellence for Development project and has served on key programs at the World Health Organization. He is a founding faculty member of the Academic Consortium for Emergency Systems and received the Presidential Lifetime Achievement Award from the Global Emergency Medicine Academy for his work. Thank you, Janis, for your leadership and for being key to assembling our panelists for today's critical discussion, Lessons from Abroad, from Ebola to COVID. Janis, the floor is yours.
Thank you, Kaylin. I appreciate the intro. We've made it so far, so I remembered to take myself off of mute, so we're ahead of the game. So, again, we live in interesting times. I think over the past 6 months, we've all witnessed the challenges that the COVID-19 pandemic has placed on our global health systems. Over the past month, we here at the University of Wisconsin Global Health Institute have started a discussion about health and health equity and what we've learned from the pandemic and how we can move forward toward a more equitable and sustainable future for all. I'm incredibly happy to be participating today, and I'm even more happy to be facilitating the discussion between our esteemed guests. This multidisciplinary group has spent their careers developing the health systems in the West African country of Liberia. Over the past decade, they've been instrumental in helping the country in its transition from war to peace and from development to implementation. It really is my pleasure to introduce them to you today and hear about their experiences in health, equity, preparedness, all the way from Ebola to COVID-19. It's really a pleasure to introduce our first speaker, Michelle Niescierenko. Michelle is a pediatric emergency medicine physician and the director of the global health programs at Boston Children's Hospital. Her program there works to improve child health globally through partnerships for clinical quality improvement, education, research, and advocacy in more than 30 countries. She has experience in pediatric care, quality improvement, and program development in many countries, from China to Guatemala, from Liberia to Turkey. While in Liberia, she's provided pediatric humanitarian aid in the immediate post-conflict setting, partnering locally with infrastructure to U.S. academic institutions for the past 10 years. Through these innovative partnerships, sustainable programs for health systems rebuilding were deployed. During the Ebola outbreak, she led the Liberian hospital public health response, utilizing a rapid deployment of training done by local healthcare workers. This work continued into Liberia's recovery phase with implementation of a national program for hospital quality improvement and emergency care training. Michelle's particular areas of interest are the provision of healthcare in humanitarian settings through systems development and the development of emergency care systems for children and the role of children in humanitarian crises. So we really welcome Michelle to our panel, and we look forward to her comments.
Thank you, Janis. I'm really glad to be here, especially with my two colleagues you'll hear from in a moment. And so the Ebola outbreak of 2014 in Liberia affected the country deeply in a way that other countries are now experiencing through COVID-19 and the effect it has throughout the world. And so advancing the slide, Ebola really set the stage. These two outbreaks, Ebola to COVID, are really very similar. The same challenges from tackling mismessaging. You know, we had a campaign for Ebola is real to ensure that people had bought into the disease, were addressing it, taking it seriously, to the same conspiracy theories that are plaguing the COVID-19 outbreak around the world. And so the work is really quite parallel, whether you're thinking about it from Ebola to COVID. And so Liberia, as you're going to hear, is particularly well positioned to share a lot of the things it learned and has used to really respond rapidly to COVID. And so on the next slide, I'm going to give you some background context and an example from the Ebola outbreak to then set up my colleagues, Dr. Dunbar, Dr. Hessou, to really talk to you about how this Ebola experience has transformed Liberia's COVID response. And so as we approach outbreak response globally, we generally think about it in a structured way through the World Health Organization or WHO pillars. There are 9 pillars, each represent a core function of responding to the outbreak. Things like coordination and planning, number 1, to case management, number 7, to maintaining the essential or the existing health system, laboratory testing, and everything in between. This is a topic that could be covered in its own lecture and its own panel, and we won't dive any deeper, other than to note that I'll talk about the existing health system, Dr. Dunbar will talk about coordination and planning, and the structure and the systems for response, and Dr. Hessou will talk about case management to give you examples of how this framework has been learned from and then applied. And so on the next slide, you'll see an extremely abbreviated, the short story of Ebola, just to give you a sense of how long this outbreak was. And so Ebola was first diagnosed in Monrovia, the capital of Liberia, in June of 2014, which is really the peak of what is referred to as the West African Ebola outbreak. There were such very visible events to the international community, such as in July of 2014, when Americans, Ken and Nancy, got Ebola and were evacuated. Importantly, internally in the country in August of 2014, most of the testing for Ebola to confirm the disease had to be done by external laboratory resources brought into the country. And we think about this given some of the challenges with testing during COVID, and to highlight this as a comparison. Similarly, a structure to manage called the Incident Management System, which Dr. Dunbar will talk more about, was implemented formally in August, so approximately 2 months later. WHO declared an emergency in September, and then as the fall and into the winter continued, hospitals had limited function, laboratory tests were able to be done in Liberian labs, and then public health hospital interventions didn't start until about January 2015, roughly 7 months in to support the return to safe healthcare services. And the total outbreak lasted about 15 months. And so on the next slide, to give you an example of that pillar of essential services, we really needed to ensure that the hospitals on this map, the little blue dots throughout it, could all function properly and safely, meaning healthcare workers could return to work and be there when a child needed vaccination or a surgery needed to be done, a baby needed to be born. And so a system to rapidly implement infection prevention and control, or IPC, was developed. And it focused on supplying, training, mentoring, and improving at each of these hospitals nearly simultaneously. And so to do this, on the next slide, it would be very difficult as a foreign institution or a foreign partner, whether it's an NGO or an academic institution, to come in and do that. The health system is very locally owned with excellent healthcare workers who are really qualified to manage their own environment. And so in a partnership called EXCEL, the Academic Consortium Combating Ebola in Liberia, it brought together the A.M. Dogliati Liberian School of Medicine, the Liberian College of Physicians and Surgeons, where residency training occurs, and universities including my own, Mount Sinai, UMass, who had previously worked in Liberia, to band together to implement this Train, Supply, Mentor, Improve intervention funded by the Paul Allen Family Foundation. And so on the next slide is an example just to show you. So when we talked about training and mentoring, this was all done entirely with a local team. And so the expertise was presented into the Liberian College of Physicians and Surgeons so that a recruited staff of physicians, nurses, water and sanitation, midwives from Liberia could take the knowledge, apply it, and mentor their colleagues. And so we did everything from hand washing and glove songs to higher level didactics. As you can see, Lydia is one of our nurses teaching the physicians and the nurses. On the next slide, if we had stopped there, which is very common in academics, and not provided the supplies to go with the teaching and education, we wouldn't have been able to empower the healthcare workers to do it. And so we had a very operational component to this project, bringing in logistical support from our colleagues at MIT to actually bring in enough supply to fill up the empty warehouses you see here, which is what we found at one of the hospitals, with some hospitals needing up to 3 truckloads, as you can see on the bottom, to really bring in enough supply to ensure they could run safely for 6 months while the supply chain was catching up to the new consumption of goods and PPE. On the next slide, we similarly had to tackle other challenges in the hospitals, ranging from water systems that were damaged or not functioning as well. If you don't have water, you can't wash your hands. And so we worked in a very flexible and locally adaptable way where each hospital provided us a prioritized list of their needs, whether it was repairing water systems, managing trash disposal, or other waste that could affect the community or the hospital. And we provided infrastructure investments, so building, construction, remodeling, to be able to fix them. And so this water pump went from being not used to fully functional, supplying one of the hospitals. And this is one of our wash technicians, Harrison, who really went the extra mile to get up on top of the water tower and figure out why the water system wasn't on. And so this is sort of an example of how we had to, as an academic group, dive into a really operational response to meet the needs of that pillar. And so these pillars you'll hear more about from my colleagues. And so I will turn it over to Janis to introduce our next speaker to start translating the lessons that were identified here with Ebola into the COVID response.
Thanks so much, Michelle. That's a really remarkable partnership, and I know that there are going to be questions later, but a really unique example of how an academic institution can partner with a development agency to really affect change. So thanks so much for that. Our next speaker is Mohammed Dunbar. Mohammed is a friend to many of us as he is a former University of Wisconsin Mandela Washington fellow who really has become an honorary Badger in his time here at UW-Madison. He has a master's degree in epidemiology, and he is a research officer at the Ministry of Public Health in Liberia. He provides regular updates on the weekly early warning bulletin and prepared dashboards regarding the status of disease prevention and control in Liberia. Mohammed is involved in community service to educate adolescents about sexual and reproductive health rights, with a real focus on teenage pregnancy, personal hygiene, HIV/AIDS, and sexually transmitted infections. And so we welcome Mohammed to the webinar, and we're really happy to have him return home to Madison, even though it's virtually. So thanks so much, Mohammed, for being here, and we look forward to your presentation.
Mohammed, if you wouldn't mind turning on your video.
Sorry, Mohammed, do you mind please turning on your video and your audio? Could be on Jesus, computer.
Sorry. Hello? Wow, technology don't fail us.
Yeah, why don't you go ahead, Mohammed? And we can't see your video, but if you don't mind muting the rest of the computers in your room, and just go ahead and we can advance the slides for you.
Hello everyone.
Good morning.
I'm sorry for the technology, but just to dive into the topic, just a quick point of correction, Valerie. The first speaker said I'm Dr. Dunbar. No, sorry. We have a female Dr. Dunbar, and I'm Mohammed Dunbar. Yeah, thank you for that correction. Well, I just have few slides to present to you to give our perspective from our COVID response in Liberia, from lessons learned from the Ebola crisis. So next slide, please. Well, as we heard from the first speaker, Liberia actually has some challenges during the then Ebola crisis, but we were able to build in our skills and try to put out some of the system in place to combat Ebola. Now, from the preparedness stage of COVID, we actually set up a community engagement strategy where we started our response by creating a surveillance system from the point of entry. That was international and local borders, where we had to quarantine, or we have to put travelers into precautionary holding center for 14 days while we were doing a temperature check, while we were observing them for any signs and symptoms. Those travelers that came from country of high risk transmission at the time, that was China. And later on, we tried to see reason to prepare ourselves for just in case, because Liberia is just another country that we were member of the United Nations, and we had to be prepared to contribute our quota. So we actually set up an incident management system that basically set up some working group, the National Emergency Preparedness Response Team, that was basically there to prepare the nation for the COVID outbreak. And we reported our first COVID case. And before the first COVID case, some mechanism was put in place. Basically, it was the IPC, the IPC measures that were taken into consideration then, because we never knew much about COVID. The continuously washing of hands, and the government came out imposing the compulsory lockdown that was about crowdedness of the places, and they had to close schools, they have to close down religious activity at a time. And the next slide will speak of when we have our first case, then some measures that were taken into consideration. Next slide, please. Now, Liberia reported our first case 16 March 2020, and then we have already put in place some mechanism for treatment that which the next speaker will speak more about that. But basically, we had to use some non-health payload, which were the security apparatus and some government and some community leaders to know how to engage the community, because we started seeing some community spread of the cases after we had our first case. Then we needed to come to see how we can decentralize the response from the national level. So we had to set up an incident management system at a subnational level, that is the county level. That is the picture you see at the bottom left. You see we have 15 counties in Liberia, and now some of our counties are in the response stage, and some of our counties are in the preparedness stage for the 28-day countdown, where they are now reporting cases. Unfortunately, we still have currently 8 cases of COVID-19 in the country, and we have few contacts we are still following up, but now our surveillance system is working in the length and breadth of the country to carry on some informed policy that will help curtail this pandemic on a national level. With no further to state, because we've seen a hotspot map where cases were being reported, and now we are trying to control the situation at a community level where we use active case finder. And those active case finders are community volunteers. They are also non-health staff that work along with the health fellows that were established to come up with some results. So I will stop here, and maybe at the question and answer session, I will try to address some of the concerns you have. Thank you.
Thanks, Mohammed. Again, sort of an interesting background on the transition into the COVID-19 pandemic. I know that there have been some questions coming in on the back end about kind of some of the preparedness measures that you guys put in place during Ebola and how that sort of affected your response this time, which we can get to in the question and answer session. But the last speaker, it's a real pleasure for me to introduce Heounohu Hessou, a friend and colleague who is a Liberian-trained general practitioner with a passion for emergency medicine and building emergency care systems in Liberia. He is currently the clinical coordinator of the National COVID-19 Isolation and Treatment Center, where the majority of COVID-19 patients have been managed in Liberia. His interest in emergency medicine was first sparked as a medical student, volunteering during the Ebola outbreak and seeing firsthand the vital importance of good emergency care systems. Since then, he has sought out much EM training as possible in the country, including spending 6 months of the intern year in the emergency department in Liberia's largest hospital and trauma center. This provided Hessou exposure to managing a broad range of critically ill patients and really enabled him to get additional training from EM consultants in ultrasound and advanced life support. So we are incredibly happy to hear from Hessou, and so I will turn the floor over to him.
Thank you very much, Janis. Welcome to everybody to this webinar. My name is Dr. Hessou, as already introduced. So I'm really the previous speakers talked about, more broad picture things. So I'm really gonna bring it down to a granular level and look at one of those pillars that Michelle talked about, which is the case management pillar, which fortunately I am a part of for the COVID-19 response. Now, the case management pillar, next slide, please. Right, so the case management pillar really had 2 objectives, and these objectives are really determined during the preparedness phase. Preparedness phase is the phase where, countries are gearing up, in anticipation that we might have a case of COVID-19. This is way back in January, February. So very early, we realized that one of the objectives was to coordinate prompt isolation and deliver COVID-19 quality care. Now, a few things went into this really during the preparedness phase. One, Mohammed alluded to, was early quarantining of people who were deemed as high risk. So people coming from countries like China, like Italy, and then eventually the US, people coming from places with high number of cases above 200. So we really had a low threshold knowing our challenges that we have in Liberia. And really, just to give you some perspective, we're able to effectively quarantine about 398 persons from February 2nd, which is the day we started with the Precautionary Observation Center, up to March 16, when we had our first confirmed case of COVID-19. Second objective really was is to equip designated isolation centers in Monrovia and around the country. So really, it was just like an assessment of what facilities are there, specialist structures that were constructed during the Ebola period, isolation centers that were built after Ebola, and really seeing what the bed capacity, human resource, and all those things that really go into that preparedness aspect. Now, I'll just highlight some of the roles and responsibility because there's a lot of them, but a few ones that are really, really interesting and really essential was one, developing a protocol and guideline for managing COVID-19 in Liberia. Of course, it's a new and emerging disease, so there's not much literature out there, but we really relied on the guidance of the WHO, US CDC, European CDC, and other bodies, that have dealt with SARS-CoV. So really, going into this, there were a few things that we really try to focus on. One was ensuring that this guideline was based on the best available evidence. Two, that is aligned with best international practices and with the WHO guidelines. And most importantly, that it was really tailored towards the local context, understanding the peculiarities of the Liberian healthcare system and the challenges involved with that. So that's how we really try to structure and develop the clinical guidelines. Coordinating care with treatment and isolation centers, as you can see, those were things that came as the cases as we evolved really. From March 16, with an imported case, and then gradually to clusters of cases like was shown on Mohammed's slide, and eventually to community transmission. So something that's really important to realize here is that as the outbreak evolves, these regular incident management system meetings, these like partner meetings and all these things are really to like adapt and strategize, as the outbreak evolves. Because measures put in place will really depend on the phase of the outbreak that you're in. Next slide, please. Now, what I try to show on this slide is really just about setting up the isolation unit and building a team. Now, what you see on the right-hand side of this slide is really a part of the clinical guidance document that I talked about. So very rapidly, and I must give credit to the team that worked on this clinical guidance document. These are, mostly Liberian experts. Most of them got their training post-Ebola, which is one of the things that you can see, translate from Ebola to COVID. And we really worked on this document. And what the intention of this was to really get cases from peripheral facilities to a centralized area. And the module of centralized care really was meant to do a few things and really accomplish a few things, One of them is that it allows us to concentrate very limited resources that we had or that we have in one facility. It also allows us to, in that same facility, do mentoring and training and centralize bringing all the necessary equipment in that facility to provide care for patients with COVID-19. So if you look at the graph there, it really shows from the community level, people that were going for voluntary testing, suspected cases from all these different clinics and hospitals and secondary healthcare facilities. This triage tool really was meant to divert all those cases, right, from triage so that they don't get into the hospital, because by the time they get in there, it's really going to cause a lot of problem, and this could really disrupt routine services. So the goal here was really, how can we keep routine services, like Michelle said, how do we keep babies getting vaccine? How do we keep pregnant women getting care while we respond to COVID? Realizing that we couldn't do it in every healthcare facility, really, really, really important. Now, the second bullet point there is multidisciplinary team. Building this team is very, very important. What kind of doctors will we need? It's a respiratory disease. So really, we tapped into the postgraduate program, again, which really evolved after the Ebola outbreak. And we recruited some really amazing doctors, and we really made sure that the recruitment of doctors was, we had a psychiatric resident, 2 internal medicine resident, a pediatric resident, an intense anesthesiology resident, and we really try to get this team together as quick as possible to start seeing patients in this facility. And I will show you in the next slide what the facility looks like. But for now, for the multidisciplinary team, it also comprised of nurses. What we had to do, and again, it shows, right, the lessons learned from Ebola here, because just about all the nurses that were recruited to run this unit were nurses who were already trained from the Ebola outbreak. So they had a very basic IPC training. They're very comfortable dunning, and dunning is like putting on PPE and duffing is removing PPE. So they had that already. So that's what really went into the thought process of a multidisciplinary team. And then training. Training, again, we already have people who have some experience with Ebola. So it was really just looking at those disease dynamics that make COVID-19 different and really reviewing the guidelines around that and providing training for the staff around that. Mobilization of resources. This is a point I really like to stress on because, you know, in a resource-limited environment, usually I like to say resource-limited environment, yes. In a resource-limited environment, what you realize is that mobilizing resources become a huge challenge, yeah? So really we had three different ways that we looked at it. One was from Central, Ministry of Health, National Public Health Institute, contributing towards setting up the unit. Second was from partners. So every partner is available in country, the WHO, the MSF, US CDC, local partners, other international partners, a host of different partners that all really form a part of this incident management system, or, you know, try and contribute towards setting up the unit. Most importantly, though, I like to stress is the community piece. And this is the piece that I find really, really important that has been behind some of the successes from Ebola to now. This community piece is really allowing community ownership and participation. Now, we're setting up a unit, we have, you know, issues with getting oxygen supply. One person step up, a private business person say, hey, listen, I'm gonna supply you guys with cylinders of oxygen for the period of, you know, your response phase. There are other people who own pharmacies, who own drugstores. They'll be like, okay, what medications do you need? How can we help? Private sector, telecommunication companies, because all these people are affected, you know, by the pandemic, whether it's from the economy or personally. So they all really contributed, and this is really, really helpful and a part of this success with from Ebola to COVID. Next slide, please. Can we go to the next slide, please? No, sorry, not this one. Not the video, please. So this video is really going to show what the unit kind of looks like, just to give you an idea of how we work at the treatment unit. So what you're seeing here is like the triage area where we usually screen suspected cases. You see all separate cubicles. Those are oxygen cylinders. And that's how we got oxygen supply for patients with severe disease. So this is like the nurses station area where we usually sit. You see everybody sitting there in the scrubs and wearing a mask. And that area there with this guy standing is where we usually done the PPE. And after that, proceed into what we call the red zone. It's the ward that have the COVID-19 patients. Now, the reason I really focused the camera on that area was really because all those steps, again, were things that we did during the Ebola outbreak. And if you notice here, you know, we wear enhanced PPE, which is really not the general recommendations for just seeing any COVID-19 patient unless you're doing an aerosolized generating procedure. However, it became really important that healthcare workers were already comfortable with wearing enhanced PPE. So getting them to, you know, wear less PPE was a bit difficult. So again, it comes back to the point of already contextualizing things and allowing, you know, the locals to really lead their way. So this is us really donning our PPE and going to the unit. And beyond that door is the red zone. So this part of this video show doffing, that's like removing your PPE. And one thing I like to stress when these videos are playing is really, really the biggest thing we always say is keep safe and keep serving. It's kind of like the motto, you know, for responding to these things. Because if you put into context, we already struggle with having a lot of healthcare workers, yeah? So our priority really is making sure that we can keep healthcare workers safe. So we really go through all these protocols step by step, and you have, the buddy system. There's somebody always watching you and making sure that you don't break PPE. Okay, I hope everybody could see the video clearly. So now we can go to the next slide, please. Exactly. So now on this slide, what I really intended to do here was just to give you an overview of the thing we talked about, building that team, setting up this unit, having centralized care. And this unit had about a 200-bed capacity. And it was really at the 14 military hospital that was newly constructed. Now, a total of about 480 patients over this time period with that small team that we have. And this data right here really shows, consistency with most of the regional and international data, where 90% of our cases are mild to moderate, 8% severe cases, and 2% critical cases. Now, somebody might ask, why are you seeing mild and moderate cases at the unit? Isn't it like a hospital? Actually, that unit was meant to do two things. One, for isolation, and two, for treatment. Because in Liberia, the general policy was or is 100% admission. So at the beginning of the outbreak, we're like, listen, it's early now. We got to get this right. Anybody test positive for COVID-19, you have to be isolated and quarantined at this designated place. And what this did was to really remove infectious people or cases from the community and get them in one location. Then do, contact tracing of all their contacts, quarantine their contacts for a 14-day period, and test, high-risk contacts. Now, the next slide there shows of the total amount of cases, sorry, not the left. Can you go back to the previous slide, sorry? Yes, so the next graph I meant shows the outcome, yeah? So we had a case fatality rate in treatment unit of 1.6%. So of the 480 patients that we saw, unfortunately, we lost 8 patients. Now, I just really wanted to show you the distribution of the severe cases, because, this becomes relevant to some people, some public health people. And you can see here that majority of our cases that developed severe to critical disease were above age 55. The next, group was between 36 to 55. Now, we didn't really see anybody less than 15 years old developing severe to critical disease. However, I didn't really want to go too much into details with the management and things like that, but really the common risk factors we saw, or we've seen now for severe disease, is actually diabetes mellitus. Next slide, please. Yeah, so this slide, I really try to show through. So that's us there doing rounds in what we call the ICU. That's more like a high care unit. We have some monitors, we have some CPAP, BiPAP machines, and there's one of our patients who developed really, really severe disease, comorbidities of diabetes, hypertension, and components of suggestive of congestive heart failure. Now, back to, we're talking all these things about how well, in some respects, we've done with the COVID-19 outbreak and how we translated lessons from Ebola now to COVID-19. However, it's not all a rosy story, yeah? There are real challenges, and it comes in with resources, risk communication. This is a point I'd like to talk about a little bit, if the time would permit me. Risk communication here is very, very important because, the disease COVID-19 is really driven by social behavior. So getting people to, first of all, even believe that it's real, especially when they don't see people falling and dying. Ebola, high fatality rate, so people are like, oh, yeah, this is real, people are dying. But now with COVID, a lot of people are mild cases. They don't get to really see the severe cases. So that was a huge challenge. Still is a huge challenge to today. Coordination also is very difficult. There's so many pieces moving here and there. You have the national IMS. You have to roll things out to all the different counties. Now, each county also have an incident management system. Each county also have all the 9 pillars, yeah? And that's how it really spreads out from county to county. So coordination can become very, very challenging. One of the big challenges, again, is laboratory. Now, again, all these challenges really are not unique to Liberia, if you think about it, because every country is struggling with the COVID-19 pandemic. So not many countries really had the testing capacity to test for SARS-CoV-2. In Liberia, however, post-Ebola, the National Reference Lab really got a lot of partnership with US CDC, with, I think, components of the US military and defense. They do a lot of research and things there. So that lab was kind of, equipped with PCR machine. However, not many. So having one central laboratory with really one functional PCR machine really limited our testing capacity. And that's one of the huge challenges that we face in Liberia, our ability to test massively, and all around the country. So with this slide, really, I will just stop here and thank you for listening. And I will be more than willing to take questions when it's time for questions and answers. Thank you very much.
Thank you so much. I would encourage all of the panelists, if they could turn on their video, so both Mohammed and Hessou and Michelle, and kind of mute their microphones. So one of the things that has come up a few times is really, if you guys could sort of articulate so of the lessons learned transitioning from Ebola to this COVID epidemic. I think that obviously your video articulates how well sort of people are prepared for pandemic control. But maybe each of you could just give a very brief, what is the biggest lesson learned transitioning from the Ebola outbreak in 2014-15 to this COVID epidemic, and what we can sort of take forward? Maybe we can start with Michelle.
Hi, everyone. I think that the key lesson for me, and I see playing out here, is in our response being completely locally embedded with an entirely Liberian healthcare worker team. When the outbreak was slowing down, we were able to pivot much more rapidly than international agencies to adapt our activities to then shift into recovery and development. And I think that the response that Nelson and that Sue have described to you really shows that flexibility, and I can see it playing out in this almost entirely Liberian-led COVID response. And so I think that's sort of the most key thing I've learned is the humanitarian to development or emergency to development context is really best championed by local leadership and local expertise.
Thanks, Michelle. Hessou and Mohammed, I mean, similarly, what sort of things from a practical perspective, as sort of Michelle said, so, local championship and local leadership in the pandemic, are there certain things that you guys can articulate both from an individual or a systems perspective that have led to your approach to the COVID-19 pandemic and sort of your outbreak response?
Okay, so I'm going to go first. Really, I would like to outline a few things. It's a lot of things. But one is really having an integrated response. And like Michelle talked about, it being really community and local expertise, led. The issue, with Liberia isn't the lack of ideas, isn't the lack of, people who have the expertise to respond to such a situation. It's really the lack of resources. Another thing is what we learned really from Ebola was political will. Very, very important. Having a political will and, very early lockdown, very early, shutting down the airport, very early putting out messages to the communities. And it would interest you to know that, the president was even involved in a campaign, with hand washing, and he even made a song about Ebola virus disease. Another thing is really strengthening routine healthcare services. Strengthening routine healthcare services becomes super, super important with, responding to pandemics. And again, that was lesson learned from Ebola. I already talked about community-led response. Strengthening core capacity to detect early and to respond early. So that's the laboratory piece, developing the laboratory capacity to really be able to detect these kind of newly emerging diseases, and really being able to mobilize assistance. And lastly, before I go on this question, is looking at it more from a national and global leadership perspective, wherein countries, can collaborate, north-south collaboration, really equal kind of partnerships to really find ways to address these kind of issues.
Interesting. Yeah, well, there's just a question that both of you guys can sort of articulate. A question just came across about the complexity of coordination piece. And so, there's a question in low and middle income countries or resource limited settings, would it be more effective to limit the number of coordination pillars, right? So I know that Michelle showed like 9 coordination pillars, and just a remarkable amount of coordination that needs to be done in general. And so could you guys talk about, is this sort of the best system, or is there something that can be done at a central level that could be adapted to different health systems, right? And so understanding that some are immature health systems, some are mature health systems, but it seems like we could dovetail that question on the back of what you guys just articulated.
I mean, I could comment from a technical perspective in responding to an outbreak, in public health. All of these components, and we hear about it in the global media right now, the challenges with testing, depending on where you are, the challenges with PPE, depending on where you are. And so the technical expertise in each of those pillars, whether it's infection prevention control or operations and logistics to get your supplies where you need them, become really important. And so if the pillars were competing for priority amongst themselves, I think your response would get stalled. And so the key is keeping all of these pillars moving forward at the same time. And so I know Nelson talked a bit about the incident management system structure, which is the formal response structure that creates the communication and coordination and keeps all those things moving forward together. And so I think from my perspective, we've seen improvement throughout Ebola to really come together to have this ready for this COVID response. And now it's what can we learn in doing COVID at this more global scale about how these pillars functioned, how IMS functions in different locations.
Thank you. Interestingly, some of the things that we have talked about in the last few weeks too have to do with sort of the psychological stress and the mental health stress, both from patients, providers, large-scale health systems. And so, there's a question that came along about sort of mental health preparedness or, in general, sort of psychological training for both for providers and for patients from the post-Ebola epidemic into now. And so I wonder whether or not Mohammed or Hessou could sort of comment on mental health or psychological resources that have been provided both to staff and to patients.
Yes, sure. So really, this has been probably one of the most challenging pieces of this response in particular, is that psychological piece. Because you go from all the way at community level, you have the stigma. Somebody tests positive for COVID, and you have community members shunning them away. So they already have that psychological stress. And then picking them up, and bringing them to the unit, seeing people dressed in fully enhanced PPE, and dealing with everything that's happening around them, we really had to hone in on providing psychological support. And again, and bringing it back to the multidisciplinary team aspect, where we really made sure that we had, one, a psychiatry resident on the team, but two, we had other mental health clinicians. Now, a lot of these programs, the mental health clinician program, the psychiatry program, residency program, these are all things that really developed, post-Ebola, and now we see here now how it translates into really helping. And again, there's a whole pillar in the IMS that focus on mental health and the mental health piece of the response. This is a very, very critical response. Peace, really, people being in isolation, that's probably the hardest thing they had to deal with being out of a facility, especially for those with mild and moderate cases.
Yes, I can, with the 12 and the 13-year-old that I've been cooped up with for the last 8 months, I feel for all parents and all providers. So thanks so much. And that's a vital, we're seeing that similarly here in the U.S., both from a patient, a parent, and a provider kind of standpoint, that there's a significant amount of mental health resources that need to be put into this. There's a question, and maybe we could put Mohammed back on the video, but there's a question about both in the Ebola and the COVID-19 response, the public health and community outreach and response being, essential. And so kind of the question is, how did these sort of come together to improve or make a much better response? So what are some of the key training and sensibilities that are core to supporting and complementing this critical response? And so how do you integrate, and that's something that we deal with here, how do you integrate the public health personnel with the clinical personnel that don't always see things eye to eye? And so how in Liberia, both during Ebola and now, how did you integrate that to optimize your response?
Okay, thank you. From the level of the ministry, we have a community assistance program, the community service program, that basically is a link between the community and the health providers. So basically, we have an existing community structure that is supporting the health system, because we have the CHA program, the community assistance program, that operates in communities that are 5 kilometers beyond the facility. So in those cases, we depend on those community health workers to refer and do some preliminary treatment at the peripheral level in those communities. But one of the mistakes I think that was done during this current COVID situation at the beginning, it was also some political will, because at the beginning, during Ebola, we have a community structure where we have community health workers that we had trained on contact tracing and active case finding. But during this COVID situation, there were some new state actors, and they decided to re-recruit another form of community health worker that also did not go well at the beginning, and there was some rift between the public and the Ministry of Health and the other public institutions. But now I think the public health system is working alongside with the Ministry of Health through engagement with community leaders and through continuous stakeholder engagement.
Thanks, Mahai. There's one of the last questions too is, I know that we've been talking specifically about Ebola and how that has sort of helped and strengthened the Liberian health system, especially in the emerging response. But there's a question about also Liberia's kind of polio eradication platform, and so how that success, and I think that Mohammed, you had sort of spoken about this when you were in Madison with the State Department YALI program, but like how did the polio eradication success strengthening sort of the surveillance system specifically? And so, I mean, I do think that you have articulated that your surveillance system is probably some of the most aggressive and some of the most robust surveillance system that I've seen to COVID that's been outlined. And so can you talk a little bit about, your polio eradication success and how that might have strengthened your surveillance system for this epidemic? Sorry, Mohammed, I think you're muted. So if you can unmute yourself, there you go.
I said, okay. Yeah, for the polio eradication, or I will refer to as the immunization program, we do have a national immunization program at the level of the ministry that have been doing significant well in getting all of our vaccines, routine vaccines at health facilities and community-based levels. So this is one of the things we keep seeing improvement in, even despite the misperception of vaccines or other international conspiracy theory. Our vaccine services is still vibrant, carry on routine vaccination services at each and every health facility, and there is still trust. So yes, the capacity is being built, and with the support from other international holder like Gavi, they are actually doing well, but I can't really give you statistics now on the difference that have been made in the immunization coverage of Liberia, but I know it is not significantly low because they are still carrying on normal routine vaccination services. It's not only polio, it's measles, it's other routine vaccines that have been rolled out in the country.
Great.
So, if I may, can I just piggyback on Mohammed's answer?
Yes.
Yes, sure. So I really, that structure that Mohammed really just described provided huge arm of, the COVID-19 response, which was really active case finding. Yeah. Wherein when we identify initially those clusters, these same people who already have some training, on surveillance with these diseases and vaccination practices are already familiar with the communities, especially in most of the county, which is the epicenter, were able to go into communities door to door and visit homes and do active case finding. And if you look at the numbers on one of the SIT rep slides, in Monserrado, for example, they visited over 30,000 homes from March to now. And through that process, they were able to refer, I think, over 500 patients, and say, listen, you're not well, go here and, probably get tested. But the ones that met the case definition weren't that many. But active case finding really is a huge component of this response, and it really piggyback on the existing structures like from the the polio and vaccination program.
Great. I really appreciate all of your time. We are coming to a close, and so I really want to thank all of our panelists for their time and their wisdom and their willingness to engage with us on this critical topic. We really thank you for all of your work in advancing equitable and sustainable health across the world. One of our paradigms at the Global Health Institute here at the University of Wisconsin is really advancing equitable and sustainable health across Wisconsin and the world. And I think that you, as our partners in Liberia, really articulate this, and we are incredibly thankful for your participation. As previously mentioned, the session has been recorded and we'll have it available on the GHI website. We really hope that the lessons learned today will lay the groundwork for actionable next steps by policymakers, program managers, researchers, and educators in the future. Lastly, I want to thank all of our attendees for joining us today. This is the third in our four-part webinar series that concludes next Thursday at the same time, so 9 a.m. on Thursday, August 27th. And so we'll find all of the information on GHI's website, which is ghi.wisc.edu. So I really thank all of you guys for being here. The last thing I'm going to do, which is last two, I'm sorry, Mohammed, you have to come up on the screen again. So as you know, Mohammed was a U.S. Department of State Young African Leaders Initiative YALI Fellow at the University of Wisconsin. And so he promised me that he would go on the screen and put up a W. So you remember, you have to put up your W, Mohammed. So I have to get it on the screen. Oh, there you go. You have to say something so I can get you on the big screen. Unmute yourself. There you go. Wonderful. So, there we go. We're sending this to the university president. Oh, there's his Wisconsin YALI pin. So, again, guys, I really thank all of you for participating. It has been a wonderful hour, and so we hope to see you next week. Thank you so much, everybody, for participating.